Go. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by Nutrition and Breastfeeding Committee of SAFOG and Artist. It's my privilege to introduce the MOC of today's webinar, Dr. Sonia Mandappa ma'am. Ma'am is currently the Secretary of Karnataka College of Obstetrics and Gynecology, Advisor Safe Motherhood Committee, Kasoga 23 to 25, and also member of Breastfeeding Committee and Nutrition, SAFOG. I welcome you, ma'am, and I hand over the session to you.
Thank you, Saiti. Good day to everyone. I address it as good day because it is good evening for us. And our eminent speaker of the day today is sharp at 11 at Switzerland, joining us on this virtual platform. So good day to everyone. The Nutrition and Breastfeeding Committee, SAFOG, in collaboration with Artist for Her, on this platform is proud to organize an important and a timely webinar on the topic maternal nutrition, the science behind optimizing outcomes. I, along with convener of this virtual webinar, is my mentor, Professor Madam Dr. Vidya Tobi. We both together welcome all the faculties, delegates who have logged in for today's webinar. Before we proceed, let's take a moment to connect through a beautiful prayer. Ms. Sahiti, please go ahead and play the prayer video. And also you can play the virtual lamp lighting together. Thank you, Saiti. Thank you. Officially, it's my honor and privilege to welcome President of SAFOG, Dr. Shyam Desai, Secretary General, Dr. Farhana Diwan, and Chairman of Nutrition and Breast Committee, SAFOG, Dr. Hema Divakar, and Speaker, Professor Ellie. And also we have Dr. G.V. Divakar with us, who is representing Artist for Her in this platform. May I now request and invite President of SAFOG, Dr. Shyam Desai, to address us with a few words.
Hello.
Yes, sir.
Yes.
Can you hear me?
Yes.
Yes.
Okay. Well, good evening to all of you. I'm speaking from India. Welcome all the audience who's listening to this webinar. It is indeed a pleasure to be here as the SAFOG president. And we have an active committee in the form of the Maternal and Nutrition and Breastfeeding Committee, which is headed by Professor Hema Divakar, who's a very, very good friend of mine and who has been doing a lot of work for SAFOG as well as for FIGO. We have an impressive program today, and we have none other than Professor Eileen, who is from Switzerland, and she's going to be talking to us on a topic we know which is very important, but highlighting the various points which will optimize the outcome of the maternal and fetal interaction and well-being. We also have a very good panel that is on maternal nutrition and or obesity and the outcome of reproduction. And I look forward to listening to all this. And I thank Dr. Farhana Diwan, who's been the Secretary General of SAFOG, for helping out with the administrative work and the entire program for the SAFOG over the past year and a half that I have been the president. I welcome you all and congratulations, Hema, for this particular program.
Thank you, Shyam.
Thank you, sir. May I now request Secretary General of SAFOG, Dr. Farhana Diwan, to address us.
Thank you very much, Dr. Sonia. I'm really delighted to be here for this very important program, webinar on nutrition and breastfeeding from the Nutrition Breastfeeding Committee of SAFOG and Artistry. Actually, artist. So Hema is a very good friend of mine, and we have been we know each other for years together. And I think she's so dedicated. I like her dedication, and she has taken breastfeeding, nutrition, especially breastfeeding, forward because it is such a simple thing, but we are not. Why should breastfeeding be 55%, 60%? It should be 100%. It is such an important thing. So the tips and tricks, the small the issues should, when we discuss over here, then everybody knows and everybody, they discuss about it and then they go for advising the women themselves. And regarding the nutrition, I think today we'll hear from Professor Eileen. I think it will be very interesting presentation, and I'm really delighted to have Shyam Desai sir, my mentor, my guide, and the president whom I'm working for a long time. He's so positive. Hema has already mentioned about it. And of course, we have Dr. Divakar sir with us. I know sir for a long time also. So I already met Pariksha before I entered, and I think Sonia and Vidya we met once again in this platform only. Yes. So I'm eagerly waiting to listen to the presentations. Thank you so much.
Thank you so much, ma'am. I now request Divakar sir, who is representing artists for her, to address this.
Hello, on behalf of artists, I welcome you all for this meeting, which is conducted by SAFOG and artists. So, Dr. Hema Divakar is there. She will tell further things about this program. Thank you very much.
Thank you. Thank you so much, sir. Nutrition and Breastfeeding Committee SAFOG Chair, Dr. Hema Divakar, who's created this virtual platform and got us all connected. Ma'am, an official welcome to you.
Yeah.
Before we move ahead, it's only fitting that we take a moment to recognize the unwavering dedication and visionary leadership of Dr. Hema Divakar. Under her dynamic guidance, the theme of World Breastfeeding Week 2025 was not just promoted, but it also brought us to life with an impactful programs, widespread awareness campaigns, and meaningful collaborations, both at the national and international level. And true to her spirit, Dr. Hema has already started to focus her work towards the theme of Breastfeeding Week 2026, that is, enabling breastfeeding, making a difference for working parents, where the theme is primarily focusing and highlighting the role of good nutrition. It's an honor to welcome you, ma'am. May I now request you to do the honors of introducing our esteemed speaker of today's session, Professor Eileen, and take the session forward. Thank you.
Thank you, Sonia. I think with the leadership of Dr. Shyam Desai as the president and Dr. Farhana Diwan as the Secretary General of the South Asian Federation of ONG, we are always enthused to do more than what we ever think that we can do, because such is their kind of encouragement and support, which only enhances our commitment. So thank you to the SAFOG leadership. And what to say about my own champions on nutrition, Dr. Vidya Topi, and on breastfeeding, Dr. Charu Bapai, who is also a FIGO subcommittee member. Both of them have taken the lead role in trying to curate some very, very interesting programs for us month on month. And Charu is also right here, visible on the screen. And the evergreen champions, as I call them, may it be Dr. Sonia Mandappa or the rest of the team from the state of Karnataka, always standing in support to do more than what I would expect them to do. So thanks again. And my very warm welcome to the esteemed faculty who represent on the global arena, Professor Elaine van der Beek, who is one of our assets at the Committee of Women's Health and Technology at FIGO, and the other national experts whom we have here, Dr. Madhuri Patil, Ms. Pariksha Rao, Vagish Iyer, and Dr. Ramesh, who will join us soon. So this is going to be an exciting few minutes in the next 90 minutes or so, where we will soak into the center theme of nutrition and the science behind the nutrition. So it's my pleasure to introduce our esteemed speaker for this evening, none other than Professor van der Beek, Elaine, as we fondly call her. The red line, the alert that I have placed at the end of this slide defines why she is so crucial to be heard in this space of nutrition. Her preclinical, epidemiological, and clinical research aims to better understand the impact of nutrition and maternal health for infant and child development, with specific attention for impact of pregnancy complications like gestational diabetes, around which we have really turned our head round in the last 2 decades. And Elaine has published over 150 peer-reviewed research papers and is an inventor of more than 25 patent applications. That's the foundation of our distinguished speaker. So tracing her career back to where it all started, Elaine holds a PhD in neuroendocrinology from Faculty of Medicine at the Utrecht University and has extensive experience of more than 25 years of research in both academic and commercial environments. After working as a postdoc and assistant professor at the Human and Animal Physiology group at Wageningen University since 1994, she joined Numico as research manager in 2000. From the year 2008, she was appointed as the program director of the new health benefits in Danone Nutrition Research. 2010 to 2015 brought her into the position of research director for the Danone Research Hub in Singapore, with a specific focus on maternal and child health, after moving back to global R&D in Netherlands, working as research director in metabolism and growth. She was appointed as professor in nutritional programming, endowed chair at the University of Groningen in 2016. Elaine is the head of Nestlé, that's her present position, Nestlé Institute of Health Sciences at Nestlé Research in Louisiana, where all of us had been invited a couple of months ago, but we couldn't make it for a different reason. But I think now this SAFOG group falling together, Elaine will definitely make a visit to your beautiful center and learn more on site from some of the esteemed researchers working along with you. And this center has been responsible for teams at the global R&D sites in VCLB and at the EPFL campus in Louisiana, next to 2 research hubs which are based in Beijing and Singapore. The research focus of the institute is in advancing nutritional research and developing science-based nutritional solutions for brain development and cognitive function, the gut health and microbiome, physical performance and healthy growth, as well as metabolic health across life stages. Well, FIGO believes in the life course approach. Right across all age groups, we consider nutrition and mental health as two very important, cutting across any age group, the 360-degree round. So nutrition is at the center of many, many things happening to girls and women, particularly across the life course. So we present to you very proudly Professor Eileen Vanderbeek for her deliberation on the science behind maternal nutrition. Over to Eileen, please.
Thank you, Hema, for this elaborate introduction. I feel very honored and privileged that I have a chance to talk to you about my passion in research, which is really to understand the role of maternal health and maternal nutrition for the health of the baby, but also for the health of the mother, because pregnancy you can also look at as a metabolic challenge in a woman's life. And many women go through this metabolic challenge multiple times. So let me take a moment to project my slides so that I can start to share my presentation with you and kick it off. Yes, I think this works. If everything goes right, you can see my presentation in presentation mode,
Yes.
correct?
Yes, absolutely.
Very good.
Yeah.
Okay. So as I said, indeed, today to really focus and zoom in a lot more on the role of maternal nutrition and some of the science behind what we think we could improve via nutritional means. And I still hold this double hat, having my professorship at the University of Groningen in the Netherlands, as well as being the head of Nestlé Institute of Health Sciences for Nestlé Research in Lausanne. I like to always start by taking a life course perspective and really zoom in what is actually life course. If you look at life, that of course starts officially at the moment of conception. And if you then think about how to actually healthy age, a lot of our focus when we zoom in on the complications that happen in later life, really zoom in on things that we can do to stay healthy for longer, to prevent things like cardiovascular disease or diabetes from occurring, and also, of course, obesity that tends to actually accumulate as we grow older. But what we've learned over the years, that interfering at this late stage, we can have major effects, and I think they have major improvements on health during this stage of life. But actually, the impact of those late interventions is relatively small. So what in the literature has gained increasing attention is to understand what happens in early life and how that may connect to your health and risk of disease in later life. And this is with a beautiful term also called primordial intervention. So to understand the risk factors that put you at higher risk to develop chronic disease in later life, and to think about those events that happen in early life that could have a contribution to it. And obviously, if you could then intervene, this might create a much more substantial risk reduction than intervening late. And what I would like to focus on today is the role of maternal health and the role of maternal nutrition and the nutrition that then feeds during pregnancy, also the child, and the role that that plays in this development. When we think about maternal health and we think about maternal nutrition, it's good to take a moment to reflect on what it influences. Because besides her own health, and as I just started off by saying, pregnancy is really a metabolic challenge to the body, and many women go through this metabolic challenge multiple times, where they have to adjust to the physiological needs of pregnancy and rebalance after. At the same time, it's also providing the nutritional environment for first the embryo and then the fetus that's growing in the womb. Initially, at the time of conception, really the nutrition and health status of the mother determines a lot of what happens during early embryonic development, but of course also this impacts early placenta development. And it's the placenta in the end that during the remainder time of pregnancy shuttles all the nutrients from the mom to the fetus, and therefore the health and nutrition status of the mom have an important impact. It doesn't stop at birth, because we also know that the sole source of nutrition that really helps in early life development is breast milk. And again, this can be influenced by maternal health and maternal nutrition status. And that doesn't start at the moment that you start breastfeeding, but a lot of that is also connected to the preparation for breastfeeding that already starts during the last stages of pregnancy. Of course, what happens after, during weaning, and when the diet becomes more diversified and becomes less dependent on milk as a sole source of nutrition, other elements come into play. And I do not want to ignore lifestyle and the environment. But I hope you understand that this early development really sort of sets the stage for how the body develops, not only in terms of capacity, but also in terms of function. And maybe that's best illustrated by this graph. Because if we think about the things that maybe can happen a bit suboptimally, it's good to take a moment and think about pregnancy outcomes. And usually when we talk about pregnancy outcomes, we usually look at, for instance, what we can already observe, what happens at birth. So it could be that pregnancy is suboptimal because there was a situation of undernutrition. This could be because of the health of the mother is not optimal. She might be young, she might be stunted, and all of these could actually set her up for not maybe developing during pregnancy the way that is truly optimal to shuttle all the nutrients to the fetus. Consequences of that could be a higher risk of having a baby that's small for gestational age, but also a higher risk of having preterm birth. On the other end of the equation, we have the risks of overnutrition that happen during pregnancy. Usually it's illustrated by the fact that the baby may have a high birth weight, which then illustrates already a bit what happens during pregnancy, but also conditions that are associated with pregnancy, like the development of gestational diabetes, but also maternal obesity, and especially when this is already present before the woman becomes pregnant, are situations that could lead to overnutrition of the fetus. On top of that, of course, we have our environment, where there might be more obesogenic diet present, and maybe a less situation that is less stimulating to have a healthy lifestyle. And all of this, of course, will accumulate. The reason why this is important and why it is good to consider what is pregnancy outcome is because we know that each of these birth states that I've depicted here may have an effect on how the child grows postnatally and how the organs in the body develop. And in the end, these are the organs that you take with you through the remainder of your life. We also have to understand that the recovery of the mom after having given birth to a child where maybe the situation during pregnancy was far from optimal may have consequences for the recovery of the mom. And of course, this is twofold. This is for her own future and her own trajectory on developing chronic diseases later in life, but it also could actually already impact the next pregnancy and create a starting point that is more challenging for the next pregnancy. Obviously, today we live in a world where there's many challenges, and I already named pre-existing maternal obesity as a condition that's becoming more prevalent, and where in the past I think we used to have a lot of concerns around maternal underweight and maternal malnutrition coming from shortage of the diet. We are increasingly facing a world where overweight and obesity during pregnancy are becoming the new normal. The numbers in this graph are absolute numbers, which explains why the numbers in China and India are really high, because we're talking about two countries with very dense populations, and obviously the representation of overweight and obesity in the pregnant population is in line with that in terms of total numbers. So even though in India you may face indeed this double burden of having both the problem of undernutrition as well as the problem of overnutrition, on this worldwide map, you already see that India turns up as a red country, actually having a very high number of pregnant women that enter pregnancy overweight or obese. On top of that, we actually know that the diet in many cases is far from optimal. Maybe we shouldn't be surprised about it because, of course, it's also one of the important drivers for pre-pregnancy obesity. I was involved in a cohort study in Malaysia where we had a chance to look in detailed dietary data collected both before as well as during pregnancy and look at some of the associations with outcome. And one of the things that we found in this cohort is that there was a clear association with the quality of the diet and the risk to develop diabetes mellitus in this cohort. There was also a risk with lifestyle and things like physical activity, but in particular sedentary behavior, even as a separate risk factor, separate from physical activity being high or low by itself, again, driving outcomes towards the pregnancy complication of GDM. We also found very clear associations with particular aspects of food, for instance, with protein intake, but also with food security, so with the diversity of the diet, but also with nutrition status, for instance, by measuring the association between iron status by doing simple measurements of hemoglobin and the risk of gestational diabetes. And then finally, and last but not least, and I think this has been repeatedly shown even across different geographies around the world, the risks of having sugar-sweetened beverages in the diet and the risk to develop gestational diabetes. With this, gestational diabetes is becoming one of the more prevalent pregnancy complications that is affecting now almost 1 in 6 pregnancy worldwide. The numbers are very different. If you go from one country to another, we might still be a bit sleeping in Europe, thinking that the prevalence of gestational diabetes is not so high. But in countries, especially Southeast Asia and also the Middle East, we know that the prevalence of GDM in pregnancy is really high, partially also not driven by obesity, but really by already developed risk of diabetes development at even a normal BMI. The reason why this is worrisome is because it affects the health of the mom, it affects the health of the child, but we need to realize that it's something that you almost, I would say, cannot let go, because it really affects our healthcare system. This type of complication can be assessed by health economic modeling, and I know it's been done for gestational diabetes to show how more rigorous diagnosis could help us to maybe have more rigorous interventions to prevent the consequences from something like gestational diabetes. And I've been involved in a health economic modeling using US data to look at the consequences of maternal overweight and gestational diabetes and the risk to deliver a baby that had high birth weight. So it's really not even taking into account any costs that would be associated with the pregnancy itself, but just looking at high birth weight as a starting point to evaluate costs that are associated with this type of pregnancy. We took into account what are the costs of pregnancy standard care. We put on top the risks that were associated with overweight and GDM, and then we looked separately at immediate consequences for the child and for the mother, and where we really divided into having no complications or direct complications, and also how much care was actually associated with it, including hospital care. So the data that we were able to analyze showed us an enormous impact of gestational diabetes and maternal obesity in this US example, accounting for 1.8 billion of total annual costs. And this is just taking into account the fact that a baby is born large for gestational age, not taking any of the longer term consequences into account. So I think I'm quite safe to say that we have to do something, because otherwise we're focusing on the wrong things. I've also been involved in a working group that actually looked at, can we do something? And this is maybe my first example where I would like to come back to nutrition. Because even though the current scientific field is quite fragmented and most of the studies that have been done worldwide are relatively small and not maybe even powered to do a thorough assessment, we were able to do a systematic review and a meta-analysis to look at what kind of dietary interventions have been done once gestational diabetes has been diagnosed, and would this change any of the outcomes. And we particularly focused on maternal glucose control and on neonatal birth weight. And our pooled analysis of a quite diverse approach in terms of nutritional intervention showed that by dietary intervention, you could achieve a decrease in both fasting and postprandial glucose in the mother, already a very clear indication that you're improving glucose control, so metabolic control during pregnancy. There was a lower need for medication treatment, so there was a lower need to, for instance, need insulin or other medication to manage the pregnancy. And we also clearly saw a lowering of infant birth weight, which directly links to my previous slide. Potentially also lowering the need for intervention and for making healthcare costs. There was a reduction in macrosomia, and all of these outcomes were specific. In the end, what this analysis also showed us was an awful heterogeneity in the outcomes. And although we're very happy with these results because it really shows that it matters to look at the quality of the diet and to implement some rigorous dietary intervention, we also realized that the results were quite different depending on where the trial was conducted. So in a secondary analysis, where we looked again at the data, but now comparing them to the regular background diet or the control diet that was employed in these studies, we soon found out that the diets were really characterized by huge differences in the balance in macronutrient intake. What this additional analysis has taught us, that although dietary interventions are very steer towards a positive outcome, the type of dietary intervention probably needs to be adjusted to what is the normal diet in the background. And if a geography is characterized by a diet that has a very high intake of carbohydrates, then obviously other dietary interventions might make sense compared to a geography where that is not the case. What was also clear that just limiting the total energy and carbohydrate intake resulted in varied effects and was not directly beneficial on these outcomes on maternal glucose control and birth weight, and that the effectiveness of the diet intervention, so the size of the effect, very much depended on the background. But overall, really focusing on diet quality, focusing on the quality of the carbohydrates, focusing on dietary diversity, were all dietary approaches that yielded very good results in this systematic review. So even though we have this promising results, I don't think we're there because there's not a universal standard for how we give dietary advice, and certainly I think we are faced with challenges of translating that to local relevance. So instead of continuing on the diet, I would like to take a step back and look at one other aspect, because I, until now, focused a bit on overall diet and macronutrient intake. But maybe it's good to take a moment to step back and talk about how important it is that we also look at the micronutrients. Obviously, these micronutrients need to come from a diverse diet and from different food sources, but it's good to realize that just giving an advice on a healthy diet may actually still not be enough to meet the nutritional demands of pregnancy. Due to all the physiological changes that happened in the body, the fact that you have to feed the fetus, but also feed and maintain the placenta, it comes with changes in micronutrient needs. And this is not universal. So there's increases in some micronutrients that are quite crucial for healthy pregnancy, whereas for others, the increased need is somehow minimal. And the graph here shows you in the light blue bars really the increase for specific micronutrients for each of them compared to a standard healthy dietary intake that you would give as an advice to any woman of reproductive age. And I hope you understand with some of these dietary challenges that I presented earlier, but also illustrated by this Australian study that actually investigated how women adapted their diet during pregnancy, finding out that some of the adaptations that women did actually brought them further away from a healthy diet instead of closer, that we have a lot of challenges in terms of meeting the nutrient demands that are associated with pregnancy. And then we need to realize that if we talk about these micronutrient needs, that actually, if we talk about malnutrition, it's really across the board. Undernutrition is associated with risks of inefficient and inadequate micronutrient intake, but we might also have a diet that is suboptimal in terms of delivering the right food sources that would meet your micronutrient needs. And even in the case of overnutrition, where there may be plenty of caloric intake, the food sources that then construct the total diet may not be rich enough in micronutrients, and it's now been shown that in many cases also obesity and overweight and overnutrition are associated with micronutrient deficiencies. So basically, if you look at the overall world map, it's almost every country in the world that is affected by malnutrition, and some countries have at least a single burden, but in many cases they have more than a single burden, and in the worst case they may suffer from all three: undernutrition, hidden hunger, and overnutrition. So if we then step back into the dietary agenda, it might be clear that to meet these micronutrient needs, there's different ways of doing it. And it's good to go back to these fundamentals before I dig in a little bit more about what I know about supplementation studies. So obviously, a very important cornerstone of meeting the nutrient needs during pregnancy is dietary diversity. And dietary food diversity, or the lack thereof, is an important driver of these micronutrient deficiencies. And especially having a mindful look at what are the nutrient-dense foods that are part of the total diet from which you need to get these micronutrients might be a good approach to see how you could elicit improvements. Then, of course, to think about foods that are fortified in certain nutrients and how we could actually plug them into the diet where there's no need to change dietary habit, and it can be quite cost effective to boost micronutrient intake is of course another interesting avenue. And then you can think about products that are generally fortified. For instance, in many countries flour is fortified with folic acid, and there's other ways to fortify with zinc or with iron. And of course, there we can consider regional differences, but this might be relevant for the overall population. What is particularly interesting, I think, is targeted fortification, where you would be able to address more specific populations, and you could segment not only based on the geography, but also based, for instance, on age, and you could even top it up with specific benefits. And I think this is, when I talk about pregnant women and I talk about pregnancy and the maternal journey, I would see this target population a bit falling into the targeted fortification. In the end, a relatively simple way to boost micronutrient intake and to achieve those micronutrient stores and intakes during pregnancy might be supplementation. Of course, you would do that in case of severe deficiency and for specific target populations, and it would allow you to personalize. Again, here you can think, of course, about what you can do more generic and what you can do personalized, and I will now take you through a few examples. So micronutrient supplementation has received a lot of attention over the past decade, and there's now substantial evidence that actually helps the community to look in a more systematic way and do meta-analysis to compare micronutrient supplementation that was quite standard in the past with iron and folic acid with the more recently developed multi-micronutrient supplementation that has now been tested and even implemented already in some specific geographies. And I think what is shown quite consistently, if you look at the meta-analysis, is that this improved multi-micronutrient approach compared to iron folic acid has the tendency to reduce the risk of small for gestational age, but also large birth weight and preterm births. And this is done in large randomized control studies, mostly in low and middle income countries. And then I talk about countries in sub-Saharan Africa and in Southeast Asia. And I've, with the red box, specifically depicted the numbers based on the different elements that have been taken into the systematic review and meta-analysis. But those are randomized controlled trials. And I was actually, over the past years, involved in a specific study in Indonesia where the multi-micronutrient supplement was rolled out in a district on the island of Sulawesi, the Parepare district. And that allowed us to collect some data to understand on what we might see with the implementation of multi-micronutrient supplementation versus the standard iron folic acid that used to be, I think, the standard for the past 3 decades in Indonesia, and see what are the possible consequences. It's a relatively small cohort of 1,216 women that were recruited via primary healthcare centers that they visited during the course of pregnancy, and it allowed us to record their weight measurements when they came in and during the 3rd trimester, and also to measure gestational weight gain. There were several interviews conducted, but this was part of the standard care. So it's not a study, it's really during implementation of the rollout of the MMS that we collected those data. The MMS was thought to start during the first antenatal visit, and the threshold they put in Indonesia for the moment was more than 90 tablets, and this differs from what the WHO has advised. It is based on the national IFA policy that was normal in Indonesia, and that's what we used as a cutoff. So what we found is that, first of all, if you just look at what happens in a community setting, if you switch from IFA to MMS, is that you can take a look at adherence. And what we found is that once women started to take the MMS, adherence was high. But in many cases, women do not come during the first trimester, which means we had a substantial number of women that actually started to take the MMS only during the 2nd and 3rd trimester. As a consequence, of course, the total number of tablets that women reached during their pregnancy was not so high. Only close to 54% of the women actually achieved an intake of more than 90 tablets, and only 3.2% had the WHO recommended intake more than 180 tablets, which is a bit of a reality check, I think, in an implementation study of this. Of course, there were effects on MMS intake. You can look at some of the drivers that maybe are associated with adherence, and we saw interpregnancy duration, BMI, anticipated side effects, so not experienced, but that women were afraid that the MMS would elicit side effects, but also having health insurance or not influenced the adherence numbers. What we did find is when we looked at gestational weight gain is the more tablets the women consumed, the higher the probability of adequate gestational weight gain. And it's the graph on the right-hand side. But what we also saw is that overall, regardless of BMI classification done based on estimated pre-pregnancy BMI, only 1/3 of the women achieved adequate gestational weight gain. Of course, the percentage of women with inadequate weight gain was much higher for the undernourished, the malnourished, the low birth weight, the low BMI women and the normal women than it was for the overweight and obese women. But even for overweight and obese, the gestational weight gain recommendations according to IOM were actually not met for a very fair percentage. So the gestational weight gain inadequacy was clearly associated with lower MMS intake. Last but not least, and I think a bit the proof of the pudding, and these are results that we are still analyzing in much more detail, is we looked at the association between MMS intake and some adverse outcomes. And we took into account preterm birth, low birth weight, large birth weight, and small for gestational age. And for both preterm birth and for low birth weight, we found a clear association with the number of MMS taken in. Of course, the study is not powered for this, and I really would like you to keep that in mind when looking at these results. But it does show that the implementation of MMS may be not seen as very successful if you look at the WHO recommendations, may have had a positive effect on the outcomes in the Parepare district in Indonesia. Now I want to shift gears a little bit because this is low and middle income countries, high representation of women with low BMI before, I'm in the presentation. I'm sorry. Give me 1 second. Sorry for that. Was somebody knocking my door? I want to shift gears for a moment because this was in low and middle income countries, and with Nestlé over the past years, we've actually done studies also in other geographies, and I would like to share those with you because it shows the universality of multi-micronutrient needs across pregnancies, no matter which geography we talk about. So we know that the micronutrient needs are also a bit stage specific, and now with the MMS, I think we have quite standard supplementation recommendations, even though they may still differ between geographies. I think for high income countries, the idea is that we don't need supplementation, and this is why I would like to share the results with you of this study. So we were involved in a study that was conducted in Singapore, New Zealand, and the UK in collaboration with the Epigen Consortium. And this is a one-of-its-kind study in that we were able to start the supplementation pre-pregnancy. So women with the intent to become pregnant were put on a supplement, and if they became pregnant, they were further included in the study and followed up. The supplement was used during preconception and pregnancy, stopped at birth, but we looked at both maternal outcomes as well as child outcomes. The composition of the supplement you can see on the left-hand side, and it differs from the multi-micronutrient supplement that is now the standard, the UniMap approach, because we really looked at the most prevalent micronutrient deficiencies in these geographies for the design of this supplement, and we topped it up with a few specific bioactives that were of interest in relation to pregnancy health. So if we look at the result, what we found in this study is that consistently the supplement increased micronutrient levels. And I show you here the example of vitamin D. It did so over the course of pregnancy when the supplement was taken in plasma, but these levels returned to normal when the supplement was stopped at birth, and plasma vitamin D levels normalized. However, when we analyzed milk, as you can see in the second panel, we saw consistently that vitamin D levels in the milk of mothers was higher in those women that had taken the supplement from pre-pregnancy until the moment of birth. I think the most important outcome, even though it was not the primary outcome in this study, is that there was a reduction in preterm birth, and this reduction in preterm birth was actually quite consistent. This is not why we set up the study. We actually set up the study because we hoped to find an impact on the risk of gestational diabetes. And I have to be honest, this study did not show did show no outcome on the risk of gestational diabetes in this geography. And we can have further discussions on why we maybe have not been able to find it. But I hope you also understand that these other outcomes, like the risk in preterm birth and also the improvement in nutrient status, are quite important. They're quite important because they were associated also with a reduced risk of premature rupture of membranes and a reduced risk in major postpartum hemorrhage. Interestingly, when we went back to the preconception data, we also saw a reduced time to conception, but only for overweight women. It did not make a difference for women that had a normal weight before they tried to become pregnant, and it actually did not improve the time to pregnancy for women that were obese, but it did for women that had overweight before pregnancy. Last but not least, it actually reduced the risk of fast growth in the children, both at 1 year as well as at 2 years. And that's associated with a lower risk of being above the 95th percentile on the growth curve, which is recognized as a reduced risk to develop childhood obesity that potentially may trail into adulthood. So I hope that with this, I've showed you also a bit of convincing arguments why, if we talk about diet, if we talk about nutrients, if we talk about micronutrients, we should actually not restrict ourselves to only think about malnutrition in the form of undernutrition, but we should look at nutrient status of pregnant women across the board. So my take-home messages are that malnutrition is associated with adverse pregnancy outcomes, and while the prevalence of maternal underweight is decreasing, overweight and obesity are increasing and sometimes in the same geography. And the prevalence of micronutrient deficiencies across the BMI range are high. Specific nutrient needs may differ across geographies and across specific populations of women, but dietary intervention may improve pregnancy outcomes. We've seen that micronutrient supplementation may hold promise, especially to reduce the risk of adverse pregnancy outcomes like low birth weight and preterm birth, but maybe in larger setting also for small for gestational age. And I think dietary advice could also have the potential to prevent adverse pregnancy complications and improve outcomes for both mother and child. It's good to recognize that whenever we talk about the first 1,000 days, to remember that it doesn't start at conception, but it really starts with the health and nutrition status of the mom, and that we need to urgently address malnutrition and micronutrient deficiencies. And that if we can improve maternal metabolic health, we might have a real opportunity to prevent pregnancy complications. So I hope with this, I've done a thorough job of putting nutrition on the agenda for this meeting and up for further discussion. And last but not least, to acknowledge my collaborators for the different results that I showed in my presentation.
Thank you so much, Aline. This was just a fantastic big canvas view of nutrition, the scientific background, and its impact that it could have. My 2, 3 simple questions, starting with the last couple of slides that are of interest to all of us as clinicians. IFA, the standard supplementation, which also the government is struggling since the 3 decades because of the compliance issues, because of the coverage issues, etc. But now we are telling them it's time, guys, to shift over to MMS. If this is the impressive outcome that we are showing with do no harm, give multiple micronutrient supplements, and there is so much that you can benefit from, how do you think we can influence the policymakers to shift gears from IFA to MMS? Because the countries like India who need it the most, we are struggling to convince because they think it's a very big shift and it's not easy.
Rima, after her answer, could I just also make
Please. Yeah.
So I think you bring up a very good point, and I think the iron folic acid policy has been there for a long time, and it's been there for a good reason. We know the prevalence of anemia and of iron insufficiency across women of childbearing age, no matter which geography we talk, and thus it makes sense to think about it. And we also know the association between the B vitamins in general, but then specifically folic acid, also with the early embryonic development and the risk of adverse outcomes. And that has driven, I think, the rationale to implement IFA policy across the board. We also know that the concentrations that are in there are actually, in some cases, relatively high and may come with some adversity and some adverse experience for the women during different phases of pregnancy. I think one interesting thing that we've learned, especially from the UNIMAP formulated MMS, is that actually the concentration of iron that's in there is lower than what is in iron folic acid. Yet if you look at the studies that looked at improvement of iron status and the reduction in anemia, the results are better with MMS compared to IFA. And it may actually go back to this idea that there's always a rate limiting factor if you start thinking about the role of micronutrients in the many different metabolic processes that we have in the body. So I think we really need to step back from maybe a more pharma-oriented way of thinking where you say you have a deficiency, you give a nutrient, you repair, by going back and starting to think holistically. Because if we think, for instance, about the carbon-1 cycle, it's not one micronutrient, it's 4 or 5 that play a role in how that actually intracellular metabolic event happens. And this is why, what is already shown is that the MMS also comes with less side effects. It's more holistic, and it really goes beyond this idea that with a single nutrient, you can actually solve things. We have to think about the complementarity and the fact that you're trying to boost the metabolism of the women because of the challenges of pregnancy. So I know it's a bit of a holistic argument, but I like that iron argument because that's also been a reason for many women not to take the iron folic acid, and it could at least be a hurdle that we can overcome.
Absolutely. Farhana, you wanted to comment
Yeah.
something, and then I'll follow up with
Yeah,
another.
Elaine, actually in Bangladesh, we are also shifting to the MMS, and we have UNICEF with us. They are doing a big study. At present, the pharmaceutical companies, one or two companies are preparing the MMS and we are giving it to women. So I didn't have an idea of the pre-pregnancy, which you mentioned today. I think that's a very good thing. And we can also do studies like this to say, well, because you stopped it just after delivery. So the whole pregnancy, the woman took the tablet. So I think
Yes.
this is something we can advocate, and after seeing the studies, we can also comment, because we are also shifting from the IFA, because we had big programs, but most of the programs are failing because women don't want to take. They have vomiting, they have
Yeah.
stomach upset and all. Yeah.
Yeah, what I find very promising from the study in Indonesia is that even though it's a small study, it's an implementation study, but there's worldwide several ongoing, where they look more what is happening in the real world if you exchange IFA for the multi-micronutrient supplement and not in a rigorous clinical trial setting. What I find really encouraging is that the trends that you see for the overall evaluation of MMS in RCTs, we actually see back in the implementation study, even though the intake levels were lower. I'm not advocating that we should say, oh, 90 tablets is enough, because we saw almost like a linear relationship, and we haven't even reached the cutoff because we had so few women that actually reached the 180 tablets. But for me, it's encouraging that it works in real life setting.
Thank you.
Yes.
I have one
Yeah,
question.
Vidya.
Yeah. Yeah. Are there any studies like trimester specific micronutrient supplementation or MMS supplementation makes any difference? Like vitamin D in second and third trimester. And we were talking in last two webinars about the magnesium and vitamin D. So there was a lot of discussion about this, and correct dosage we wanted how much to be given, because we cannot minute deficiencies we cannot test by blood test or something like that. So are there any means guidelines or any studies you have with you that can guide us really, and for our guidelines and other things?
So it's a very good question, because you're totally right, and I showed this graph that already depicts the crucial position that some micronutrients have during different phases, indeed first, second, and third trimester. But you could also look at lactation and postpartum recovery as such a special period during the maternal journey. The recommendations until now are quite generic. There's starting, I think, to come some expert committees that are looking at it. I saw a recent paper coming from an expert group in Europe, where the first author was Irene Setin from Italy, that has looked with more an eye to high-income countries, putting it on the map that you cannot ignore because you think we're fine in high-income countries. And then I was actually at the American Society of Nutrition, and I know there's a working group looking into this, where they also try to embrace more holistically this idea. If you make it more complicated by saying it's even trimester specific, how can we ever convince not only healthcare professionals but also the consumers? So they actually did talk about what you could do from a tech point of view to drive those recommendations, which I think, Hema, feeds into the FICO working group on women's health and femtech solutions, where we have to bring much more granularity on what we're trying to advocate. I think for me, there's a step change into recognizing that with micronutrients, we might be able to do a lot, and then go into the complexity should we become more specific for the different stages of the maternal journey. But I recognize what you say. Yeah.
Thank you.
Actually, the sad part is, Eileen, that Make in India, MMS is happening, but it's all getting exported because Indian government has not agreed to the.
Oh, wow.
Because they're going to many low middle income countries, and now they're toying with an idea of IMMS. They want to just change the UNIMAP formulation a little bit, adding the I there for India against IMMS, but it's a long way to go because the iron content which you mentioned, that is looking like a sore point. But what we are trying to convince the government is that you're thinking you're giving 60 or 100 milligram of iron, but it's anyway not being taken, nor being absorbed, nor being effective. And we are anyway landing up with giving them parental iron. Instead of that, it's okay if we are giving less iron, but there are all
30
very
milligrams.
important things which are coming around it.
Exactly.
But
And
the
these code
clinicians,
factors may in the end help, and that may
yes,
explain why the improvement in iron status is not different between the two. And it's half of the iron that goes into the MMS. Yeah.
yes. And then I also was trying to convince the government that clinicians today in India are super confident of plugging the iron deficiency by parental iron because it has come to us with ease. So, guys, let us give them MMS. By mid pregnancy, if their hemoglobin status iron deficiency is not plugged in, you can always give a parental and carry on with the MMS the rest of their journey because it has so many more advantages in terms of outcomes that you've just mentioned. So, this is the group now which have to spin their heads around in the whole of
Yeah.
South Asia, do some
Yeah.
more studies to prove that it's worth shifting from
Right.
IFA to MMS. That will be the flagship goal of Eline's talk today. And much appreciate that you mentioned the fortification, because rice fortification, just like we did the iodized salt, iodine fortified with salt, and similarly rice fortified with double I, that is iron and iodine, is what the government is trying to do. But we have still a long way to go in promoting and propagating the fortification, but that's another important prong of attack. And lastly, the FIGO nutrition checklist, which has come as a
Yeah.
simple rescue factor for most of the frontline paramedical staff, which quickly administers the FIGO nutrition checklist to at least recognize the gaps and the nutritional deficiencies so that further on the right advice can be given. So points very, very well taken. And the way you so eloquently explained the scientific facts and tagged it with the importance of nutrition right across the life course will always, always not only be remembered by us as clinicians, but also pay the attention it truly deserves. So thank you very much, Eileen, for your kind presence and participation in today's SAFOG webinar brought to you by Artist and SAFOG. And we will now move on to the next part of the session. You're welcome to stay on, Eileen. I don't know what time of the day it is, but I really appreciate that you gave us not only a valuable time, but so much insights into what we should be doing to move the needle forward. Thank you so much. Thank you. Over
Thanks,
to you,
Hema.
Sonia.
Yes. I must say that we joined together to word out and thank Dr. Hema because she was the primary responsible person to open Professor Ellen to this virtual platform. Thank you, madam, for that insightful and thought-provoking talk. And your presentation was perfect blend of science, and there was more clarity with clinical references and clinical data mentioned, and with quite promising results as well. Now, as Madam
Thank you,
said,
Elaine.
SMS,
Thank
it is
you.
now MMS. Now it is MMS. I was just thinking, it was M for Mark, the micronutrients, another M, at the SAFOG platform from all the faculties and delegates. So we take back another MMS with us after Professor Ellen's lecture. Thank you so much, madam.
Thank you.
Let's move on. Now, much awaited time to explore the critical link between obesity and reproductive health. We are privileged to have with us a panel of distinguished experts, each pioneer in their own respective fields. To moderate this panel, may I now invite dynamic leader who is flying the flag of nutrition at the national and the international level, now Vice President-elect of FOXY, Dr. Vidya Thobi. Over to you, madam.
Thank you very much, Sonia. And at the outset, I must thank Dr. Shyam Desai, Dr. Farhana, as well as our leader, Dr. Hema Divakar, who is always churning our head and the plate also. She has brought in that GDM plate with us, and we always show every patient of mine, they are very fond of that. Today is something, a very great topic for the discussion is, I think, hope I am sharing my screen and everybody is able to see the screen.
Yes, it
you
has
would.
one slideshow. Yeah, that's perfect. Yeah.
Perfect. Okay. So I'll just, okay. So I again welcome Dr. Hema Divakar as an expert who is a Division Director of Well Woman Health Committee of FIGO, Chairman Nutrition and Breastfeeding Committee SAFOG, Dr. Madhuri Patil, who is the Chairperson of Aspire, and she's a Vice President ISAR 21 to 25. And she has got many accolades. She's an Associate Editor of Fertility, Sterility, and many publications to her credit. Dr. Vagesh Iyer, we all of know, he's a professor, Department of Endocrinology, St. John's Medical College, and former president of Karnataka Endocrine Society. Dr. Pariksha Rao, uh, she serves at the National Advisory Board for the Impact for Nutrition and has been trained at AIMS and ICMR. So, and Dr. Ramesh Makam, who is a bariatric surgeon and consultant at AB Hospital, his CV runs in pages, but I have told only 2 lines about everyone. Okay, so we are something discussing a very huge burden on us, that is obesity. And obesity in women is a complex issue, and that also encompasses both lifestyle and medical and surgical consideration. Now, we all know that the lifestyle factors, we all talk of diet, exercise, and all those things for the obesity control, but it is increasing. And one must accept that it is a disease, and disease with the genetics and environmental influences. So it is always, we talk of multidisciplinary approach, which addresses to the lifestyle changes, and whenever necessary, medical surgical interventions, which is often required. That's why we have brought in a galaxy of our all panelists who are the experts in their own fields, and they will be talking and discussing about this complex disease. Now, WHO has described obesity as a global epidemic, and it has got a significant health risk to the woman, not only during pregnancy, during preconceptionally, postpartum, and all long-term health implications what we are worried about. So this is a title of World Obesity Day, which was recently celebrated, that is a changing systems and healthier lives, which calls for the systemic change to ensure a healthier tomorrow. And this is what FIGO says, that it is the most common condition in women of reproductive age. So it affects at least 10 to 40% of the women and other adolescent. Now, Dr. Ms. Modi, our Narendra Modi, our Prime Minister, has also declared that it is going to be obesity epidemic in India, and nearly 44 crores of Indians are likely to be obese by 2050. So it is a very alarming situation, not only in the world, also India. Obesity, we all know how it is to be defined, and we know how to calculate BMI. So we also know that it is not only BMI, but also the waist hip ratio, which we have to calculate. 25% of the Indian population and 39% of the women, they are suffering from morbid obesity. And this is how what we calculate from our BMI calculator. What is underweight, normal range, overweight, pre-obese, and again obesity is classified into obesity class 1, class 2, and class 3. Now this is how the picture looks like, the morbidly obese, that is BMI 40 or more, that is class 3. And it has got all sorts of complications, right, from PCOS, cardiovascular diseases, dementia, non-alcoholic fatty liver disease, mental disorders like depression, hyperlipidemia, diabetes, hypertension, and cancer. So for all panelists, this is my question, that we all know that obesity is a growing concern across all age group of women. So we are getting more and more teenage and adolescent obesity as well, and to the menopause. So, what, according to you, is the biggest missed opportunity in preventing obesity in girls and women? Anybody can take this.
Can I take it?
Yeah.
I think primordial prevention is the role we miss during a pregnancy. I think it's a proper care taken during a pregnancy. I think that will yield a proper long-term results. It has been very well said that 9 months stay in the womb almost decides rest of the life. Probably
Yes.
that's the one place where we have to act, and that is the most effective way of intervening the obesity. Even the model of a SGA and also LGA both have shown that in the long term they lead to the not only obesity, even the metabolic problems.
So healthcare professionals who come first time is a gynecology obstetricians, right? So obstetrician should learn how to tackle this. That's what Dr. Madhuri. Yes, Dr. Madhuri.
It should obesity begins intrauterine. So
Yes.
it is the mother's health which is very, very important. And therefore it has been seen, especially in women who have PCOS, they have hyperandrogenemia. And then combined with the environmental factors, it can affect the fetus. And basically, usually this results in small for gestational age babies. And then because of the Trepti phenomena, once the baby is born, it gains weight and there is obesity. And then this is also influenced by the social structure which is there in the house, because if the baby is small, they overfeed it and then it becomes obese. And once becoming obese, it really, takes a lot of trouble for them to lose weight. And therefore, today, a lot of adolescents are obese. So I
Yeah,
think
Doctor.
begin with education of a pregnant mother, and therefore the obstetrician is the first person who comes in contact with these patients, and it is them who should really educate the patient. And I think a lot of today obesity is associated also with infertility, and I feel that when a patient comes to an infertilologist, it's very important depending on the age, because if the age is more than 37, then we normally would not wait, for her to lose weight and come for conception. But before that, definitely if she comes, we would advise her to reduce her weight, correct her hormonal abnormalities, and then go for pregnancy.
Yes, so that is a healthcare professional should be aware how to counsel these pregnant women, what is the proper weight gain, that we will be discussing later. But obesity stigma and the psychological binge eating and emotional this eating is also at increase. So, Dr. Ramesh, any
Yeah.
comment from you?
What I feel is you mentioned about girls and women. The today's problem has been stress. Stress eating has been a huge thing. The second thing that I could also add is the regulatory authorities. If we do not cut down the amount of calories in each of the food that is available, either in restaurants or packed foods or whatever, I think we're getting into too much carbs and sugars, and that is something that is addictive. And once they get addicted to that, it becomes very difficult to get them out of it. So these are some issues that we have to look into.
Karnataka, I must say the Karnataka is the first state that who have banned the junk foods in the schools as well as 100 meters surrounding the campus. Pariksha, she wants to tell something about this. Yes, please
Yes.
unmute. Yeah.
Yeah, thank you. So I think the problem, we know how deep it goes. And today, I think from the diet diversity, which is becoming really poor, we are talking about maternal nutrition and the maternal health for setting the tone of the next generation as well, which is so true. But the missing piece here was the gut microbiome. And with the diet diversity reducing, stress and cortisol increasing, the entire estrobolome is going for a toss. And that's where we are seeing higher infertility, poor fetal health, poor pregnancy deliveries, and so on and so forth. So I think starting from the womb, yet the connection of nutritional diversity, mind, body connect, and getting the gut microbiome right, I think those will be the stepping stones to tackle this in a holistic manner.
Right, right. So this is a supplement article which is published recently, and that is a management of obesity across a woman's life course. That is a FIGO's best practice advice, and they have divided as a classification from stage 0, stage 1, stage 2, stage 3, and stage 4 according to the obesity related risk factors, physical symptoms, psychological symptoms, and any functional limitations, and how to tackle them. So they have again means they have taken into account the WHO classification also, and predominantly the risk factors. Now, how to tackle? They have given a pictorial guideline, which is very important. One is ask permission, talk properly with this, and take the history properly, assess their story, listen to patiently. What then advice on management depends on the medical nutrition therapy again, as Pariksha was talking about inclusion of all taking a history of their gut, what they're binge eating, what they're eating, exercise, psychological factor, medication, and think of bariatric surgery in some of the cases. And all should agree on goals. So it is again a multidisciplinary approach for treating this obesity, and these are all interlinked. That is what the FIGO guidelines say. Now, should this obesity in women to be viewed primarily as a lifestyle issue or a disease requiring medical or surgical interventions? First, of course, we talk of lifestyle, isn't it? So, what are your comments? It is a lifestyle issue, everybody should agree, what I feel.
Yes.
And then comes medical intervention or surgical intervention. Even they come for surgical intervention, it again starts with the lifestyle issues. Yes, Madhuri?
Before we label a patient as lifestyle issue, it's very important to rule out any disease which is there which can cause obesity. I think Nagesh and Dr. Ramesh will definitely agree with me that we cannot just say, oh, it's a lifestyle issue and just leave it, and then probably the patient has some pathology in there.
Yes, sometimes epigenetic, sometimes other diseases really come. We always talk of genetics. If there is no answer, then there is always genetics. That genetics is there, and that is the reason, because because many patients, they come like that. I eat this much only, but I am obese. So for that, we don't have answer, because their calorie count and whatever the calorie structure is there, we see that calorie is very less what they're eating. Then comes the genetics, isn't it? That way, definitely we will do. Yes. So if then it is a combination, lifestyle as well as medical and surgical intervention. We are going to talk later. So if a adolescent girl comes and she talks how to avoid obesity, what is your advice individually?
I think the first
Adolescent obesity, yes.
Yeah. So primarily, I think it's important that the girl gets to understand um, the knowledge, attitude, and practice is what I'm talking about, right? They would have seen their families or their parents or their mother struggling later in life with knee pain. First is their own health, right? Their quality of life. And then is a new mom to be, new mother to be. So I think the counseling begins with their knowledge levels to be improved. I think nutrition should be a part of every college curriculum, every school curriculum. And that's where we will understand that taking care of our lifestyle is our own responsibility. Today, I think so much happens in our country also culturally that we get swayed away. Like if the family believes that after pregnancy or during teenage years, a girl has to eat X amount of ghee, I'm just picking up an example, we think that's good. Whereas that particular individual has the gut microbiome to digest that and utilize the energy efficiency, we don't know. So it depends on body to body. Maybe one girl can digest it, the other girl doesn't have the estrobolome to take care of it or digest it. She or he will get fatty acid accumulation and adiposity. And we all know about adipogenesis and the turnover.
Yeah.
Right. So that hormonal balance for an individual coming from early understanding and taking control of their own health through nutrition practices in each household, I think that's where we will see some bigger change.
Yes.
I think a cognitive behavioral therapy along with psychotherapy is also very important, especially in adolescent girls, because I think that forms one of the arms of treatment for obesity in the teenage girls.
Yeah, that is. And I want to ask Dr. Ramesh, how many adolescent obese girls you have done this bariatric surgery?
Our adolescents, we've done more than 70 to 80 girls who were very morbidly obese and who had health issues. So these are we have a higher threshold for picking up girls in adolescence. But then when they're getting into health related problems, we have to go in and do something for them. It could be severe obstructive sleep apnea. It could be severe metabolic response, like they have developed diabetes. We've had patients with cholesterol of 1,500. We've had some people who had severe hypertension. In spite of taking 12 tablets for antihypertensives, they were not controlled. So such patients, we definitely have gone in and we've been very happy that such severe cases which were life-threatening could be saved by bariatric surgery.
Really, it is very alarming situation, right? We really come across adolescent girls undergoing bariatric surgeries and having so many complications like morbid obesity. And tackling this morbid obesity by bariatric surgery at such an early age, really it is alarming. Now, this question is for Dr. Madhuri. How does obesity impact ovulatory function and assisted reproductive technology outcomes? And do you follow any specific protocols, any medication adjustment or fertility drugs if you are treating any obese infertile patient? And what all protocols you use?
So first thing what we need to know is that the pregnancy rate is almost 4% lower per kg square meter increase in the BMI. And it has also been seen that the live birth rate decreases by 9% in overweight and about 20% in obese patients. So this is an important factor of what we need to know. Second, we need to know that it can affect the menstruation, which can result, you can have precocious menarche, you can have irregular cycles, you can have oligomenorrhea or amenorrhea. It can also result in sexual dysfunction. And basically, it affects fertility because it results in hyperinsulinemia and hypoandrogenemia. And this is more so in patients who have PCOS. And basic problem is it results in anovulation. It can also, and the incidence of infertility, as I said, is almost 3 times higher. And it can also influence the treatment because it can result in poor response to the fertility drugs. You require higher gonadotropins. There's also higher incidence of cancellation of cycles, altered endometrial function, and lower success with ART. And it has been seen that it basically affects the endometrium because obesity and inflammation are correlated, and therefore it can alter the gene expression in the endometrium as because of the production of the pro-inflammatory factors and also the activation of the immune system, and then this can result in compromised testosterone of the endometrium and therefore decrease implantation rates. It can also impair the endometrium basically because of leptin resistance and in the peripheral tissue, insulin resistance and hyperinsulinemia, and it can also affect the ovarian follicles because it has been seen that there are increased levels of C-reactive protein and TNF-alpha in the follicular fluid in patients who are obese. And this then can result in abnormal mitochondrial function in these patients. It can also affect the embryo quality, and it has been seen that at ART, the embryo quality isn't good, especially when the BMI is more than 30. And it can also, after an ART, it can result in decreased fertilization rates as well as decreased cleavage rates, and you have decreased number of good quality embryos, apart from decreased number of oocytes being retrieved.
So, in these obese infertile patients, do you refer to an endocrinologist like Dr. Vagesh or you treat yourself?
No, so treating obesity basically depends on 2 factors because You have to also know that there are certain non-modifiable factors like the age and the ovarian reserve. So if the patient is 37, 38, or even if she's less than 35 years and her ovarian reserve is very low, wherein her AMH is less than 1, I don't think I'm going to defer my patient and I'm not going to wait for her to lose her weight. But if she's young, her ovarian reserve is good. So definitely we would go ahead
So
and
age and ovarian reserve, these are the two factors on that you will decide, right?
yes. So, and basically, these patients, you tell them for lifestyle modification, but it does not help, and especially in PCOS women, in case they have impaired glucose tolerance, or if they're really overweight or obese, then one could add metformin. There are also GLP-1 agonists, which I think Vagesh will talk on. But then we have to remember that if they are on this drug, you have to stop them for 3 months before you go on for any infertility treatment.
Yeah, yeah.
Not conceive as when they're on those drugs. And I think I have also read somewhere that once you stop this GLP-1 agonist, the patient, the woman again regains weight. So I'm not very sure, but I've read about it, and I
Yes.
think Bhagesh will tell us more on it.
Yeah, he will be talking about that. What about this preconception weight optimization? We always talk that it will improve the outcome. So in
That's
your
what I said.
case,
It will
yeah, you
totally
told
depend
about your
on
success
the
rate.
and the ovarian reserve. So
Reserve.
I don't think, I mean, we would advise that before.
Yeah. So I just come to now Dr. Vagesh,
Yeah.
that we know that insulin resistance and PCOS are intertwined with obesity. So how you will differentiate primary endocrine cause or secondary metabolic outcome from these obese women? These all resulting.
See, I think majority of obesity, what we are dealing now is a polygenic.
Yeah.
Monogenic, we can to a greater extent, we can differentiate right from the childhood history and then when they enter adolescence, like developmental delay, if they have got any organ specific disorders, and obesity with some amount of a short stature or even a bodily dysmorphism. So that is altogether different category that we can handle separately. But what is more difficult to handle is a polygenic obesity. And it has been very well said that nearly 2/3 of our PCOS patients are obese. 2/3, and that is almost increasing. Now there is a small entity of a lean PCOS.
Lean
We
PCOS.
face similar problem with them when it comes to the obesity. A weight loss of more than 5%, almost results in more than 80% of ovulatory cycles. That has been very well documented in PCOS. So once weight comes down, insulin resistance comes down, and we have seen the patient,
and if the patient wants to conceive early, whether drastic weight loss you will advise?
It depends on, as madam told, at what age they are seeking us. For example, if they are late in the reproductive life, then probably we have got a shorter period to achieve this. If they are early, probably we have got a longer. It has been very well studied with the GLP-1 receptor agonist, even the Monzero dual agonist available. Some of the women have conceived while on treatment. In fact, this is a weekly injection. They have been conceived. Till now, I think well into close to 1,000 babies are there, wherein they are exposed to this GLP-1 and dual agonist. They are exposed during a pregnancy. Means as soon as pregnancy is diagnosed, they have stopped it. But those babies, they have followed. And as of now, it appears safe. But still the standard recommendation is keep a period of 3 months. It is just a conservative. It's just a conservative. Keep a 3 months period before
that
they
is
go
a
for a
washout
planned
period you want to
pregnancy.
say. Yeah, washout period. No?
Yeah,
3
washout
months.
period of 3 months before they go for a pregnancy. If somebody wants to lose morbid obese, we know that their pregnancy complications are more when they enter with those so much of obesity. Better to reduce with a medical therapy or a pharmacotherapy. Then I think we can make their pregnancy much more safer, because when they conceive and they have a problems, it is a double. We have to take care of a mother, we have to take care of a baby. Both are a challenge.
Yeah, yeah. So
Yeah,
in
one more
mother,
thing I would like to tell Vidya, that in the Indian population, the WHO BMI does not apply. So basically, it is overweight when the BMI is more than 35, and it is obese when the BMI is more than 25, as against 25 for overweight and 30 for obese in the other population. So I think this is an important factor which all of us need to keep in mind when we are looking at our patients.
yes. What are the other anti-obesity drugs you use in the management?
I think
Apart from GLP-1 receptor agonist, Any other drugs you are using for the treatment of
In
adolescent
fact,
obesity?
the agents which have shown a promise is GLP-1 receptor agonist and the dual agonist. They are.
Dual agonist.
And there is use of a orlistat for some time, but it is a not ideal drug. Hardly 2 to 3 kg of a weight loss with lots of GI side effect happens. In fact, they are successfully used now that even recent paper has come before availability of many of these drugs. We had used a combination of a metformin and a topiramate. Obese girls with a thing with a fair success. Only this last 2 months back, we got one of the retrospective analysis from one of JCM telling it is also good to lose weight.
Okay.
But losing weight with a medical therapy other than GLP-1 receptor agonist and a dual agonist, it's quite difficult. Metformin, only certain people lose weight. It's not uniform. In fact, there are subset of patients who lose very good weight with a metformin, though it is not such an excellent drug for a weight loss. We have seen somebody losing 10-15 kg, 10-15 kgs. This is mainly because of their OCT1 polymorphism in the action.
Yes.
So as of now, I think our thing is mainly we use metformin, then move to the GLP-1 receptor agonist, either injectable or oral, then the dual agonist like a tirzepatide.
But this injectable, how long you use, or injectable followed by oral you do, or how many? Is any side effects if you use that prolonged treatment? Yes.
GLP-1 receptor agonist is available for more than a decade. We are quite comfortable using, but the weight loss is anywhere between 5 to 7 kgs. Probably weight is very high. Probably they may lose more. With tirzepatide, which is available in India from past 2 to 3 months. So we have seen just initial experience. We have not used in any PCOS or anything. We have used in obese women and all with a good promising thing. I have got some 20-30 patients on tirzepatide with good weight loss with reasonably reasonable safety profile I see, because most have some or other GI complaints. But
and do you advise contraception again with this drug?
In somebody who is sexually active with the reproductive age group. Fine, that's been done, because we know that we don't know what is the effect of this on the growing baby in the womb. So as of now, a contraception while are on tirzepatide, stop ideally 3 months before planning for a pregnancy.
Yes. That is what we wanted from you, but it is very difficult, as you told about it is a polygenic orientation, and about the PCOS management with obesity is very, very difficult. And to convince and counsel the woman, once the drug, they withdraw, and then again there is a weight gain.
Yeah, rebound weight gain is a known thing with all anti-obesity medications.
Yes. Yes. So once the medical line fails and there is a morbid obesity, we talk always of surgical intervention. And now, Dr. Ramesh, I just wanted to know that, as you told that there are 70 adolescent girls you have operated, means you have done the bariatric surgery.
Yeah.
Are there any concern with the future fertility or pregnancy outcomes post-surgery, and how patient selection you do, and what care you take of these women, and what is the difference between the management in women compared to men? Because obese men also has got infertility and other problems, right? And they also face the challenges of non-communicable diseases and chronic diseases. So this question particularly for you, because you have done so many bariatric surgeries.
Yeah, thank you for that question. Basically, what we look at when we are talking about ladies with morbid obesity is most of them, we are looking at somebody who is going to become pregnant and how they face their pregnancy, and then how they face the rest of the problems in life. Now, fertility rates is definitely very good when with bariatric surgery. Weight loss, we all know about it. I don't have to elaborate that. Earlier, before we had all this GLP-1 agonists, we had a huge number of patients being referred by mostly infertility specialists for obesity management. And we have had almost 100 patients who have had bariatric surgery, and all of them had healthy pregnancies. Uh, the only thing that they have to be knowing is the initial 6 months to 9 months, their food intake will be less. So
Yes.
it is recommended that they try for fertility only after this particular period of time. The second thing is you talked about preoperative preparation and all that. So the first evaluation of a patient is like a general evaluation. We have to first rule out each and every cause for obesity, which can be corrected. So it could be as small as a nutritional deficiency, a B12 deficiency, or a vitamin D deficiency, hypothyroidism. So a few genetic causes. We look at everything and then we have a very thorough evaluation, not only for the correcting factors, but also to reduce their problems during surgery and to have very good post-operative outcomes. So nutritional assessment is very important before any surgery. And whatever vitamin deficiencies or iron
Have to be
deficiencies
corrected, I think. Yes.
have to be corrected before taking them up for surgery, and we also have to keep using those supplements post-operatively.
Yeah.
Regarding the changes that we see in these patients, especially patients who do well, who have lost weight, who become pregnant. After that, there is a small issue with them. They try to they after pregnancy, there is a percentage of patients who start putting on a lot of weight.
Oh,
So what is important is the first 3 months, we always advise them to come to us. How we maintain them during the first 3 months after pregnancy, how we make them reduce weight, have a healthy diet, not having too much ghee and other things, and keep on bed rest or house rest and be active. All these are very important issues. So they can maintain whatever weight they have lost. And this is a major flaw that we see in patients who had bariatric surgery and become pregnant later.
yes, yes. And
Otherwise, there I don't see much of a difference of how we manage men and women. This is the only issue that we have
issue
found.
they have. Okay, okay. So these nutritional deficiencies to be corrected, and usually you take minimum waiting period. They say that it is around 12 to 18 months after the bariatric surgery,
Yes.
and you advise them the contraception in these patients. Have you seen any
Yeah, but
surgical
though we
complications?
say that,
Yeah.
I mean, just to mention about it, practically what we see is they're so frantic to get pregnant that we've seen one patient who was 45-year-old, had
Mm.
5 IVFs, failed, came within 4 months, she became pregnant. But so
Oh.
we've
So,
had patients.
Dr. Madhuri, how many cases operated by Dr. Ramesh come to you?
No, I have not seen a single patient who's undergone bariatric surgery, basically.
If you refer, then you'll get back.
Yes.
All the patients coming to me are 39, 40, 42. I don't think I can refer to them for bariatric surgery.
Yes, yes.
I was just joking.
Yeah, yeah, sure.
But what I want to say is, in my own practice, I've seen patients never had problem, even if they became pregnant a little early. The baby's birth weight was good, growth was good.
Yeah, they
We,
say
we
that
give them
there are so many
supplements and they do well.
complications. Yeah, complications in baby also. What about surgical complications? We are very fearful about these gastric band slippage and hernias and all those things, no? So are they very scary complications which come across you have come
See,
across?
it is like any other evolving science.
Yeah.
Initially, when something comes, then you definitely see some complications. It is for various reasons. One is the equipment that we're using, the
Yeah. Now
staplers.
endoscopic surgeries have come, no? They have
Yes, yes.
balloons and all those things. Endoscopic surgeries and minimally invasive surgeries have come. So the
Yeah.
rate of complications have come down, really.
Even surgical complications have come down with expertise building and pre-operative and peri-operative management, and the technology, the staplers and everything have become foolproof. Earlier, there were failures in stapling of the devices and all that. Then today we know that they are all 100% safe. So we do not have any complications at all. Now, for the last 22 years of my practice, I have not seen a single mortality till today. That's
Great, great.
because of these.
Expertise. Yeah. Thank you very much. And this is a short systematic review and meta-analysis and bariatric surgery and its impact on fertility, pregnancy, and outcome. It is very interesting article I read, and they say that some contraceptives, what we can use, women with obesity or without a history of bariatric surgery, which we can use. So these really in MEC wheel, if you see, then these some of the contraceptives are contraindicated, like combined hormonal contraceptives because of obesity and the risk of thromboembolisms. But patch and rings can be used. Now, I bring in our Dr. Hema Divakar, who is an expert on this, and she has done many this one guidelines. She was an expert on FIGO as well as SAFOG, and I just want to know about how what complications you have observed more frequently in pregnancy due to obesity, how you have tailored antenatal care in such cases, and how the nutrition checklist you have used. And this I just wanted to mention about the pony initiative, which you were the part of that. So I want your comment on this.
Thank you, Vidya. Rather than calling myself as an expert, I
Mhm.
can very, truly confess honestly that holding these organizational positions as nutrition, breastfeeding chair, for example, or FIGO, pregnancy and long-term complications, pregnancy, obesity, nutrition, initiative, etc., has personally sensitized me a lot towards the menace of obesity and actually the importance that we have to give to weight, undernourishment, malnourishment, obesity, the triple burden, as we call it. So, my role chiefly has been to really sensitize as many care providers as possible for the importance why they should think nutrition first. That is the tagline of FIGO as well. And there, first when I looked at the FIGO nutrition checklist, I thought it was so silly. Some just, 4 points you took, just tick mark, what's a big deal? But then that big deal was also not happening anywhere. So now what we're doing as a part of our training program for groups of paramedical personnel in every hospital, we are instituting the FIGO nutrition checklist, which can be administered to any patient, pre-pregnancy, pregnancy, post-pregnancy, adolescent, anyone. There are different target groups. So because it's across life course that we have to pay attention to this issue. So it takes 2 to 5 minutes. That's all. Just after the preliminary data, initial thing, sensitive thing is whether they're vegetarian, non-vegetarian, vegan, vegetarian, etc. Because the food groups that they start asking them about, like proteins, for example, whether they'll ask mungfali or whether they'll ask fish, that they should know, because some people, they just get very averse to the kind of questions. So after that preliminary check, we teach all the paramedics what are the food groups, how many times they're taking. Especially a lot of data we get on pastries and cool drinks and such things that they are almost taking daily, but fruits and vegetables they may be taking only like as infrequently as twice in a week. So eating right is the main thing that we emphasize on. So the gaps are very glaring when you administer the FIGO checklist. And then when it's sent to the consultant's table, we have less time, we know, but we still have to pay importance to this and counsel the patient, because to my mind, obesity, I always tell my patients, it's like a magnifying glass. Whatever problems you have, it'll just blow up. That's the simplest thing. But as Madhuri said, it is very easy for them to get depressed because they say, doctor after doctor, we are going and they're telling the same things.
Same
And I'm
story.
trying my best, doctor, but still I'm not getting anywhere. And, so it also, we have to be sensitive to be in their shoes and more of a supportive and motivating and reassuring and encouraging care provider rather than shooting them with useless, you've not done much. And because lifestyle is easy to talk about.
Exactly. Yeah.
And the points that Pariksha said, we were not even aware of so many things about gut microbiomes.
Gut
We're just opening
microbiome.
our eyes into those. So all the pregnancy complications, obesity, that BMI calculation also with great difficulty we brought it to their blood group, RH typing, BMI, with great difficulty we brought it into their clinical notes. Okay, once they identify that, what next is something that they have to think. And if they just pay attention to the fact that yes, this is obese or morbidly obese category, then they should shift their thinking to all kinds of risks that can happen, inclusive of the early trimester miscarriages, malformations, mid trimester unfolding of the GDM, comorbidities of hypertensive, then the risks during deliveries, and the
So many
non-healing
things.
wounds,
Yeah.
and you name it, you'll have it. Your problems will just multiply. In short, that is the message.
Yeah.
That, you have to, and then also thromboprophylaxis post delivery. That also is becoming an increasingly important thing, not
In
to
the
ignore
obese.
or neglect. So all the way through, we have an important role to play, both in recognition and trying to do our bit about it, and also guide her through inter-pregnancy care, where the first pregnancy she may have gained a lot of weight, but how does she manage to lose it? That is also a very, very crucial point where we have to guide her towards optimal, BMI, etc. So I
Yeah.
think we, in our own understanding and um, trying to dialogue a bit about this with the patient, has enormously increased in the last 2 to 3 years. And that's why we even having this cross speciality discussion, so that we understand more and we do better. I really, on my own behalf, also have to thank this brilliant faculty which are giving so
Yes, very
many,
much.
so many insights, and you, Vidya, for calling me an expert for
No, no, no. Really,
being
please,
but we know that we have hammered this into lots and lots of clinicians to start paying attention and
I do
thinking it's a
agree.
serious part of their prescription. Don't
Yeah.
push it under the carpet. Start learning and start doing something about it.
Yeah, one is the nutrition checklist and weight first. This line is very important. Think nutrition and weight first. This is a
Yes,
pony initiative, and
absolutely.
really, I have seen many. We did just a survey that how many weighing machine in the clinicians really they are working. Are they doing that BMI really properly? They are not bothered about that. No? Just
Yeah.
they prescribe about iron, calcium, and just let it go. But
Hmm.
what is the root cause? Really, it is to be discussed very seriously.
Yeah, we
So,
were doing a training program in Kanpur. So very nicely the BMI, Samanya Sthiti, then Motapa and Aswastha
yes,
Motapa and
Motapa.
all this. So that is the terminologies that they use, and then for the first
And
time
in
they understood.
many communities, Motapa is a good health. That is another barrier we are
I
addressing.
agree.
Yeah,
Yeah.
yeah.
So I think
So these
lot
are
of
the
value.
various barriers we have to address, like lack of time, routine weighing, information gaps, and as well as patients confirm. Now we bring in a gut specialist as Pariksha, and we are really we wish to know the insights, the emerging evidences for the gut microbiota, how it plays a role for obesity, and what dietary interventions really positively influence gut health in these obese women. Pariksha, really, we are very eager to listen because this is also insight for us.
Thank you so much
Yeah.
for the question. And I think working with pregnant women with last 2 decades, I think I was also puzzled where people are making maximum effort in behavior change, even then they are not losing weight. And that's where the whole work on gut microbiome started, at least for my learning. And where the gut microbiome dysbiosis comes from is a vicious circle. So if we understand the poor eating pattern, the stress, and the work-life balance that every woman is facing today, be it at any strata of area of life that we are looking at today, the whole cortisol level is disrupting gut microbiome at the starting level. And secondary is the changing eating pattern in our country. The diet diversity has gone for a toss. Where we used to eat local food, so I'm a big believer and quite vocal for local. That's where the whole problem is beginning, when the gut dysbiosis is taking place. Yeah. And we Indians, being a carb digesting population, we are more Previtola heavy when we talk about our gut type. We are not protein digesting population. And that's where the thin fat India phenotype also comes into picture, because we have the tendency of gaining more body fat, and adiposity comes with it. And the whole metabolic programming that happens is happening in the womb. So like I said, that your mother's gut microbiome and even a father's gut microbiome today has been reported and very, very well studied in contributing how a life in early 5 years and later in life will have non-communicable diseases or any complications for that matter. And we all know that the microbiome, which is fed the right food, will produce its own short chain fatty acids or the different end metabolites. With the gut-brain axis, it will take care of your cortisol or your mood, and even the serotonin produced in gut. It will take care of most of the stress levels, and the vicious cycle will be halted at some place or the other. That's where a simple understanding of what works in a particular region, going back to roots and eating the diverse food that an Indian specific region has practiced, from our grandma's kitchen to our kitchen, that's the missing link.
And even seasonal food, no? Seasonal food we
Absolutely.
used to eat, yeah.
Absolutely, absolutely. And that dysregulation or upregulation of adipogenesis, which is happening with poor metabolic programming, that's happening in early life as well as in adolescence, that's where the problem begins. And more white fat cell increase happens. When the cell size has increased, I can still reduce it. When the fat cell number is going on increasing, it becomes very difficult to burn that cell itself. So we can definitely reduce the fat cell size, but to burn that, now it's gone into your genetic programming. And that's where we see maximum problems with weight plateaus and other things. So it's such a balancing act to understand a body type, what their regional food habit is, where the stress is coming from, and definitely make sure that the microbiome is taken care of. And when I was looking at Professor's slide, she also in the MMS has
she has written prebiotics. I also noticed that.
Yes, yes.
She has
Because
noticed
that's the missing link that from the last 2 decades we are studying. And gut microbiome, like you know, is a very nuanced science. We have just scratched the surface, right? So it's very important that we dig a little deeper. We also did a clinical trial where we have seen a massive correlation with right probiotics in a clinically efficient dose, along with the right intervention on lifestyle. We have seen 12% reduction in body weight and fat percentage per se. So a lot of science is getting addressed around it. And I'm sure with this.
So I just want to ask you, what is a prescription? Suppose a obese girl comes, means adolescent girl, and I want to prescribe, right? And I don't know what her gut microbiomes are, or what is a general prescription you would like to give. This is a complex. This is a one article I just went through, and what to eat, lose. This is a common question, but we were discussing about the pre and probiotics, no? So what prescription you will give for losing weight in these girls or any female obese woman?
Right. So first thing is our, like I was saying, traditional diet. Let's not forget about our seasonal probiotics that used to sit on our tables, from our kanjis to buttermilk to our chas, right? Those are the most important. I think that's vanished from our table today. Let's bring those traditions back and start incorporating that. And definitely, see, our foundational microbiome as a human being remains same. We need to fix that first. And over and above is the layer for an hormonal or an estrobolome that comes into picture for an adolescent girl. So first and foremost will remain a very good probiotic coming from natural sources, be it kanjis, be it beetroot kanji, be it pickled vegetables, be it brined vegetables, whichever way. And then having a broad spectrum probiotic coming from lactobacilli or bifidobacteria family. But there are specific genre of bacteria today that are studied and correlated in changing the fatty acid utilization by production of GLP-1 in the body. That's where the reduction in body weight is also seen and reported. So
Yeah.
that can be a good way of understanding how sticking to our plate method, which Dr. Hema and I are a big fan of, right? It's very simple. We do not have to overcomplicate it. Yet, when a person has already reached a overweight and obesity status, it needs a little bit of supplemental support to bring that weight down and then continue with healthy eating.
Healthy eating. So this is a prudent our normal diet and the Western diet. In Western countries also there is obesity. What about their microbiota?
Completely
That
different.
is completely different, right? We are just following blindly the Western diet,
Yes.
which is not, we cannot digest it because our whatever the flora is there, intestinal flora is totally different.
True.
But
True.
what about the Western obesity? What treatment they should take? Means they have a high protein and high fat content they eat, no? So for them also the prescription remains the same.
So again, for them, a different probiotic composition might come into picture, but the fundamentals of the diet will remain absolutely the same. The right type of soluble, insoluble, and resistant starches. Today, I think we need to definitely talk about resistant starches and its role in feeding the gut microbiome in a sustained manner. And then Mediterranean diet remains on the top, no doubt about it. Understanding that if we are born and brought up in south of India or in the western counterpart of the world, we need to understand they are protein digesting, we are carb digesting population, and our microbiome fundamentally is human on that level. But again, there is a layer of a predominant bacteria that will digest fiber and carb, and theirs is preponed and preset to digest fat and protein. Yet their food is so ultra processed. That's where the monogenic and polygenic obesity load is coming in there. And if you look at the trend of obesity increasing in India, is the correlation that you'll see with adaptation to Western diets, sadly.
Yeah.
Right.
Yes. So it was really eye-opener for everyone that we are just losing the touch of microbiomes and the whatever the flora, and we should revert back to our original diet. Now, at the end, just I want to have a few things about the what should be the ideal care for the obesity in women from all of you. How you are going to treat if in a general practitioner, if a obese adolescent girl comes or any obese woman comes, how you are going to treat her. So
I think
yeah,
psychological counseling is very, very important because usually obesity in these patients, they have a body image distress.
yes,
And therefore, we have to basically negate that for her to really motivate her.
yeah,
Motivation is the most important thing about losing weight. So,
agree.
and when we are counseling her, we should tell her about the diet. We should tell her about the exercise because it's not only diet that's going to help. And in exercise, it's not only aerobic exercise, but you have to have weight training because weight training is going to increase the muscle mass, and increase in the muscle mass is going to decrease her fat also. The second thing is we have to see whether she really has an opportunity also to,
Support.
exercise and also going for a diet because it depends upon what is the atmosphere in the house and whether she has time to go and exercise or what are her commitments. And today we know that most of these teenagers are so electronic savvy that
Heavy. Yeah.
they're always on the phone. And probably, I think that's the most important thing. And at this stage, it's very important that we should not ignore that there could be some biological or any systemic conditions which are contributing to obesity. And these conditions basically require personalized care.
Yes.
Altogether, a multifaceted approach which has to be done, and multidisciplinary team has to be involved. We should have the gynecologist, should have the endocrinologist, the nutritionist, as well as the physiotherapist, because all of them will only help her to reduce.
Yeah, Dr. Hema always talk of digital health and digitalization of all our health problems. So I want one comment from her, how it can help to tackle
I
the
think
obesity.
the myths around this obesity and the problems can easily be decimated with gamification and some other interesting modes on the digital platform, which right across the age group, whether the adolescent, reproductive age group, and menopausal, everybody is quite savvy with it. So it should be interesting and significantly driving a message with whatever they write. It will be very engaging for them to understand what it is, because they should know it's only not cosmetic, but it's medical and health issues that largely we are really wanting to create awareness about, and eating right and the things which we talked about. It can easily be escalated through a constant driver through digital health. So we are totally hooked on to creating reminders and buzz and rebuzz across the lifespan in different ways, which is appealing to different socio-cultural backgrounds, and some animations, etc., which has no language barrier, but it effectively conveys the message. So
Yeah,
it
and
requires a lot of creativity and a lot of thought process behind it, but it is so worthwhile, because
worth.
each one, if they recognize for themselves, then it is a lot more of an impact that we can uh, probably achieve in the shortest possible time. So that's my one point about that. Yeah.
Yeah. So we have come to an end, but it is very, very vibrant, and we learned a lot from each one of the panelists, and they have put in their extra effort and their expertise, and
Does Dr.
yeah.
Vagesh and Dr. Ramesh Muttam
Ramesh.
has any advice for OBGYNs?
Yes.
Vagesh,
Yeah.
How many
Most
OBGYN?
tell me
important
what
is,
we are missing, what we should be doing.
I think
Missing link.
postpartum thyroid disease screening. That's the most important. I feel that's the one place where many women gain weight, then only they come. And second thing is overfeeding the mother. I think
Oh, yes,
that's the
yes.
most important. Yes, right nutrition is important, but overnutrition is definitely wrong. And this obesity is a family wise. I get some family telling probably she doesn't fit our family because she's very lean. I think that to that extent we have got a families to selling.
Absolutely.
So I think those things should go away.
Thank you,
Yeah.
Vagesh. Dr. Malcolm?
Yeah. The thing is, once there is one person in the family who comes, I think we have to call everybody and treat everybody. We show that person and say, you kids should not become like that, and then start putting them on competition. Who's going to lose weight? So when two people are put on a competition, we see it is better because one person brings chocolates and ice creams. You tell the other fellow, don't eat. It doesn't work. Second is, what we are looking at is a lot of call centers and IT people in Bangalore, and the sleep rhythm is completely buggered up.
Yes.
And along with this, it is the screen time. Everybody is on the screen. So if we cannot just ration the food, we have to ration the screen time. We have to make sure that they sleep at the right time. These are very important. And I tell them, live in moderation. Eat moderately, exercise moderately, don't get stressed too much, and then sleep properly. I think all this is going to really help them. And educating the whole family is something that we should concentrate on.
Yeah, I agree, sir, Ramesh, because family, अरे अपने family में तो सब लोग ऐसे ही
सब
हैं.
लोग
It's a family thing,
स्वस्थ है,
doctor.
स्वस्थ है.
अरे, and the Shield Healthcare, they always put two frocks, one small frock, one big frock. Sahithi, you are there, I guess, listening to all of us. So from the big frock, we to fit into the small frock. That is Shield's message. Yeah.
Sonia wants to
Sonia?
tell. Yeah, Sonia.
Yes, ma'am. This is a question to Madam Pariksha. Madam, what is your take on nowadays we are speaking more about microbiome sequence testing and gut microbiome, and then specific strains can be recognized, and then we can customize a probiotic for the individuals.
Customized for individual, that is important.
Yes. So we usually, when they come for obesity and a lot of the IBS or any other symptomatic treatments, so we are actually advising them for, though it is very vast, it takes a lot of our time and energy to read through the reports. But then I think that's the best way we can customize a probiotic for them. What's the take on it?
So yes, I think gut microbiome testing today is possible. I mean, it's happening very at a large scale in India as well. Cost has come down. Initially, it used to cost about 20,000. Now the cost has come down to 7,000. Genomic sequences labs are growing in the country. Sample collection is easing, like a path lab. They will come home, collect the stool sample and take it. And of course, because it's the DNA sequencing that's happening, it's going to take at least 4 weeks for the complete panel to be studied and reported back. Where we are trying to compare, we always need to be mindful that there is no gut that you will compare it to, and still the data is getting accumulated, right? So your gut microbiome can have a signature and you have no symptoms. Same signature if I have a symptom. So again, like any path lab report, you have to correlate with it. But yes, there are few things that I definitely keep in mind, which is their short chain fatty acid production score, their antibiotic resistance score, and their antibiotic recovery score, which gives me the understanding of this person's strength in the microbiome. And they also measure the alpha diversity and beta diversity. So once we look at the beta diversity, that means how many types of bacteria you have. That is directly correlated to your immunity, your fatty acid regulation, and many things, right? So like I said, diversity and your microbiome diversity. That's the core for health.
So these microbiomes are going to replace all medications.
Precision medicine looks like it. I can't use the word replace, but it looks like a very promising therapeutic support as an adjuvant, as a first-line therapy also. I'm a firm believer that
Still
as a first-line therapy,
on
sorry.
it. There's
Sorry.
still not much evidence on it for
Yes.
testing the microbiomes.
Absolutely. So labs need to get
What
standardized.
people give is empirical probiotics or prebiotics, but testing still does not have any evidence, and a lot of theories are coming in, but actual evidence for testing and treating is
It
still.
will evolve, Madhuri. We're on the way.
Yeah, that's
No,
what.
Just start.
Coming-
It will come.
Can I make a comment here?
Yeah.
Yes.
I think we are currently doing one symbiotic study wherein traditional
Symbiotic,
food
yeah.
is being given for a type 2 diabetic patients along with the medication. And I think 1 year, 1.5 years, we have collected their stools and we have extracted their DNA and we have intervened for 4 months. Again, after that, we have collected their stools. We are waiting even the control sample. It's in St. John's. I'm being the PI. We have been funded from one of the private agency. And it's a quite exciting. At least metabolically, they have shown an improvement.
Yes.
So now we have to study their gut microbiome and to see whether they have just changed. Only traditional food which is used in the South India has been given in a quantified way to them.
No,
in fact, fecal transplant is a major.
What we used to eat is the best food rather than what we are eating today.
Yeah.
So I think we should change that eating
Can I
habit.
make a comment here?
Gut
Yes,
microbiome.
yes. Yes, Professor Farhana.
Yeah, actually, it was actually very nice discussion, but I think we need to talk more about the gut microbiome. Because I listened to a very important question that what will we advise when these girls, the obese girls, comes to us, and how we will advise them regarding their diet and their food habit.
Again, it is individualized, right? Individualization because everybody's microbiotas are different. We cannot do that tailor-made treatment.
Not required, Dr. Toby. Like my experience in the last 15 years that I'm working in this space, more and more experience is that you first set the basic right for the gut microbiome. For example, that the balance of a firmicutes versus bacteroidetes. So there itself, your inflammation in the body can be studied, or how the metabolic programming is changing by this balance itself. So one is pathogenic in nature, one is protective in nature. That itself is the biggest thing for us to strike a balance with. Then comes a layer of an individual. Maybe some individual has a pathogenic bacteria like an E. coli or a Shigella, which is not letting them get to the right ecosystem within the gut microbiome. So that is a very small portion of population which we do therapeutic support. A particular bacteria for diabetes, a particular bacteria, not a particular, a family of bacteria in synergy along with prebiotic for autism or for obesity or for other diseases. So the science today is establishing and identifying and putting a therapeutic solution for sure. So that much science has evolved, and I'm sure, I mean, going further, it's going to become stronger and stronger with the research that is happening around the globe.
So then it will be evidence-based, and then Dr. Madhuri will agree for that.
No, today also it's becoming evidence-based. Like we
treat our patients, but we're treating them empirically, basically.
Yeah.
That's what I'm trying to say.
Agreed.
No, Madhuri, everything evolves from a point, but the positioning of gut microbiome, which we heard about 8 years back, the omics and the microbiomics and all, it was such a mind-boggling thing and couldn't understand a word of it really. Saying, where are we going? What is this all they're talking about? And the stool testing and variety of intense research that they presented. And slowly when we started paying attention to that, we have improved step by step in our understanding. Not yet, but what should we be asking for and what should we be supporting with the prescriptions, where this will go and reach, how it will help. Slowly, this is yet another major armamentarium which has come into our circle of things, which is again challenging us to do more than what we are doing today. So I think another 5 years time, it will become a norm. When we actually talk about precision and individualized medicine, some of us at least will already be executing that in practice. That is the dream to reality
They are
journey.
implementing an abnormal microbiota. They're saying gut microbiota can also affect the vaginal and the uterine microbiota, and therefore it is one of the causes of recurrent implantation failure. They are also relating the gut microbiota to PCOS. There are a lot of studies which have come out, but
because everybody's exploring, you see, whether we are not hit upon many things, but we are on our way. That is something which is, come to stay in our thinking process, in our controversy process, in obtaining the clarity and trying to see how we can do things better with inclusion of this in some of the aspects of our practice. So I think Pariksha is really a value add to this panel. Thank you so much, Pariksha. I just included her in the last moment because this was really, in a way disturbing my mind about where are we going.
But it is an
this
important
aspect. So that's really nice. Yeah.
Thank you so much. Thank you so much.
Thank you very much. And here we come to the end of our brainstorming academic session that is on obesity. So let us fight obesity and put on our all energy, whatever we are. So in our practice. And very means we have insightful opinions from Dr. Madhuri, Dr. Ramesh, then Dr. Vagish, as well as Dr. Pariksha. And I'm very much thankful for expertise from Dr. Hema, and I'm very thankful for Professor Farhana. She was there for the lecture as well as
thank you,
panel.
Farhana.
Thank you, Farhana.
I enjoyed so much. Thank
Thank you. Yeah.
So thank you very much, Dr. Sonia. Can you put a vote of thanks? Or
thank you, Madam Dr. Vidya Tobi, as usual, at a very good moderation, and always your mantra has been think nutrition first. Though Motapa is a good word to many, but not very soothing for you is what you made us realize. And obesity is not just a lifestyle issue, but a critical determinant of fertility and pregnancy outcomes. And together at this virtual platform with the multidisciplinary panel, you've clearly dictated the complete complex relationship between obesity and reproductive health, from hormones to fertility to surgery to microbiome, which is driven solutions. So it's a very clear and loud take-home message. And we all thank the entire panel and the moderation and the expert opinion and Dr. Farhana staying all through for joining us at this platform. And I think it's time for us to wrap up. Over to you, Madam Dr. Vidya, for Code of Thanks.
Vidya, can you stop sharing the slides and we can have
Oh, okay. That is a thank you slide.
Yes. No, because by the time you talk, we want to see you properly.
Yes. I'll close it.
Yes.
So I immensely thank Dr. Sham Desai and Dr. Farhana, who are the SAFOG office bearers, and always they support us for all our programs. And the speaker, Professor Ellen, who put in her entire research and on maternal nutrition, and it was very elaborate, and we learned a lot about the various trimester specific multi-micronutrient interventions from her, and looking forward much more from her in future. And this obesity, and I think the pariksha, I think I need more and more. Ye dil mange more, like so I need more literature on microbiomes. And I first thank you, and then other panelists on the board. Madhuri, as usual, she puts her all evidence-based things, and I am always a fan of her. Whatever she speaks on, I always tell him about it. The infertility part and the obesity, I think so many obese patients must be coming to her for infertility treatment, and the evidence-based treatment part on obesity and how it affects the fertility part, she has nicely elaborated on that. Dr. Vagish Iyer, endocrinologist, he clearly mentioned about the various medications which can be used for the treatment for obesity, and really looking forward for whatever the research part you have mentioned, please share with us so that we can also study on that. Then Dr. Ramesh, he has done 70 bariatric surgeries on adolescent. Really, it was an alarming statement, and for me at least, because in our northern Karnataka part, not many obese patients are there, but in the, I think, urban population, the obesity is on the rise. And it has got a behavioral component also, and many times we have to take a help of psychiatrists. That is again additional point we have to highlight on that. So I immensely thank all the panelists who have joined and all the delegates they have joined for us today for this academic session. I thank Dr. Hema at the last, because she is always, how many times I should thank her, because always she will ignite our knowledge part. And I really searched and researched about all the topics like microbiomes. I have so much I read about that I want to discuss with Pariksha. That's what I was talking to. Thank you very much, Shield, that always they are our partners. I thank Dr. G.V. Divakar, who always are with us from the Artists for Her. Sheetal must have joined, and I also thank Charu Bapaye, who is also FIGO Breast Health Committee member and chair. Thank you very much.
On behalf of all of us, a big thank you to Dr. Vidya Tobi
Thank
and
you very much.
Sonia for connecting the dots, and thank you
I have
very
not
much.
used any language which is very, very